Let's talk about how we work up and treat patients with pulmonary embolisms or that we suspect may have a pulmonary embolism. There's different ways you can work these up depending on how high risk they are for actually having a PE. For patients with low risk, so we have a less than 15% pretest suspicion of a pulmonary embolism, you can start with the PE rule out criteria, or the PERC, P-E-R-C. I wrote rule out here because these are rule out criteria, not rule in criteria. Just because a patient is PERC positive does not mean you need to work them up for a PE. If you have a suspicion of a PE and your pretest probability is low, you can go to the PERC. If they fail any of these, you have to work them up further for a PE. The PERC criteria are age greater than or equal to 50. This is positive. Heart rate greater than 100. O2 saturation less than 95%. If they have unilat leg swelling, one leg is swollen. If they have any hemoptysis, if they've had recent surgery, that's less than 4 weeks. They've had surgery in less than 4 weeks. Or if they have a history of a PE or a DVT. And then finally, if they're on any hormones. So the ones that get us here are the oral contraceptive pills. If any of these are positive, you need to continue. If all of these are negative and the pretest probability is less than 15%, you're done. You don't have to work them up any further. The ones that get us most often are age greater than 50. You cannot use this on anyone older than 50. And then always, in your younger females, ask about oral contraceptive pill use, because hormone usage is a positive PERC, which means you cannot PERC them out. On low pretest probabilities, we start with the PERC criteria, and if those are all negative, then you're done. You don't have to work up the PE anymore. Now, I keep talking about risk stratification. How do we determine what our suspicion is, what our pretest probability is of a PE? And the answer there is we use the Well score. This is going to help us work up PE when our PERC is positive and we have to do further workup. When you do your Well score, if it is less than or equal to 4, you go to a D-dimer. If it is greater than 4, you want to go directly to a CT angiogram of the chest. BQ scan, not as good a test. If at all possible, you want a CTA of the chest. So if it's greater than 4, you go straight to CT. The reason being, if the patient has a Well score of 7 or greater, if they're high risk, with that pretest probability, even in the setting of a negative D-dimer, your post-test probability is still 15% of having a PE. So a negative D-dimer does not rule out a PE in a high-risk patient. That's why it's only used in lower-risk patients, less than equal to 4. Some sources will say less than 6 you can continue to use the D-dimer, but definitively less than equal to 4 on a Well score, you can rule out with the D-dimer. Now, if the D-dimer is less than 500, you're done. They're negative. In some assays, that's reported out as 0.5 rather than 500. If it's less than this, you're done. That's a negative D-dimer. You don't need a PE. The other thing you can do is you can age adjust the D-dimer. So you can take the patient's age times 10, and that's their new cutoff. So anybody below 50, 500 is their cutoff. But if you have a patient that's 60 years old, we multiply that by 10, their new cutoff is 600. A patient that's 80 years old, their new cutoff is 800. So you can raise that cutoff in patients that are over 50. And again, if the D-dimer is negative, you're done. You don't need to work up PE any further. If the D-dimer is positive, if it's greater than 500 or greater than their age times 10, then at that point, you need to go to advanced imaging, such as a CT angiogram. This is the basic way you navigate the workup for a pulmonary embolism. Now let's say I did my workup, I did the CTA, and I have a PE. What is my next step? The next step is to evaluate for right heart strain. So any patient that has a PE and has evidence of right heart strain is more worrisome. The ways you can evaluate for right heart strain is one, on the CT, they may see a dilated right ventricle and they may tell you based off the CT report, there is right heart strain. That's not great. 2, probably the best, is doing an echo. Do an echocardiogram, see if you see any right ventricular dilatation, see if you see any right heart strain on your echo. You should be doing an echo on these patients. And then finally, you can look at labs. So if you have an elevated troponin or if you have an elevated BNP from this pulmonary embolism, that is right heart strain. So you want to evaluate for right heart strain. If there is no right heart strain whatsoever, you have a non-massive PE. Non-massive PEs just need anticoagulation. You can do a PE severity index to further evaluate your patient. Talk to your attending. Some of these patients can actually be discharged home. If it was clearly provoked, you have a low PE severity index, they have good follow-up, they can potentially be discharged home. Otherwise, you want to anticoagulate them and put them in the hospital. Those are our non-massives. Now let's say you get the CT back and you do the echo and you have a really dilated right ventricle. What's our workup? When I have evidence of right heart strain, the next step is to evaluate hemodynamic stability. If they're hemodynamically unstable, the most common indication of this would be a MAP less than 65. This is considered a massive PE. Notice I didn't say anything about the clot burden. I'm not talking about saddles. Sometimes saddles are massive, sometimes saddles are non-massive. It doesn't matter what the clot burden is, it matters what it's doing to the right ventricle. If you have right heart strain and you're hypotensive, this is a massive PE and this needs thrombolytics. There are a lot of new interventions and therapies for PE. There's catheter-directed thrombolytics where they put a catheter into the pulmonary arteries and shoot the thrombolytics directly on them. There is a therapy where they go into the pulmonary artery and they use sound waves to break up the clot. There is clot retrieval where they can go in and pull out clots. But right now, the clear evidence is a massive PE benefits from systemic thrombolysis. So if you have a patient that's hemodynamically unstable with right heart strain from a PE, you need to give systemic thrombolytics. Here's where it kind of gets muddy. If you have 1, a PE, and 2, right heart strain, but the patient is hemodynamically stable, this is called a submassive PE. And the management here is not as clear in the literature. Some of it is based on anecdote. The evidence can be contradictory at times. Here's what I do. Submassive PEs that look sick. So they've got a history of chronic hypertension. Every time they're in there, their systolic's 180, and now their systolic blood pressure here is 120. You look at them, they just don't look good. You do your echo, you've got your left ventricle over here, your right ventricle's over here. This wall's not squeezing at all, and you see the apex winking. McConnell sign, write that down. On those patients, they're technically submassive, but they look terrible. I'm probably going to give systemic thrombolysis. I'm probably going to give a full dose of thrombolytics to this patient to try to break up that clot. Because again, while technically they're not full massive because they're hemodynamically stable, they look bad. I'm concerned they're headed there. If this patient looks like $1 million, their echo looks really good, but maybe their trope is just a little bit elevated, their BNP is just a little elevated, well, yeah, that's evidence of right heart strain. Technically, that's submassive, but they look phenomenal. That patient, I'm going to start them on a heparin drip, and I'm going to admit them without thrombolytics. You always want to do a heparin drip on these submassives because if they get worse and they do need thrombolytics, you can shut off the drip and give thrombolytics. If you give Lovenox or low molecular weight heparin, or if you give an oral anticoagulant, that is probably going to create a contraindication to systemic thrombolytics if they decompensate. So if you're admitting a submassive without giving systemic thrombolytics, you want to start them on a heparin drip for anticoagulation. This is the very, very basics of how to evaluate for and manage a patient for pulmonary embolism. There's a lot more nuance to this, but this will get you started.